Hi, I'm Dr. Leonard Faye. I'd like to thank Dr. Carl Cleveland of Cleveland Chiropractic College for sponsoring the reshoot of these tapes that were originally done in 1980. But over the years, there's a lot that needs to be added, and thanks to Dr. Cleveland, we're going to be able to do that. I also want to thank Dr. Dennis Anthony for supplying the Leonard table, which has a lot of specifics, techniques that we can demonstrate that I think you're going to find interesting. And I'd also like to thank Dr. David Gafkin of mopalstation.com, who supplied the motion palpation station. Very, very important instrument in order to do the palpation well. But if you haven't got one of those, just use 2 stools and you can get a similar result. Adjusting is a psychomotor skill, and the levels of learning a psychomotor skill go from conscious incompetency to conscious competency, and to a practitioner who's been in practice for a few years achieves a level of unconscious competency. And quitters quit when it becomes consciously, they become consciously aware of being consciously incompetent, and instead of persevering, they give up, and as a consequence don't learn as much technique as they should. And hopefully these tapes will help you in learning the psychomotor skill. It's been shown by research that we learn psychomotor skills by mimicking somebody who's very good at it and then practicing perfect. To practice imperfect isn't going to get you the results you're looking for. And I'll be mentioning that not only do you have to mimic postures and the thrusts that I do, but you have to learn to feel what I'm feeling. So I hope to be able to describe what I'm feeling, and you'll see what I'm doing, so that will be mimicking, and then it's up to you to practice. And practice does make perfect, and it's the way you learn a psychomotor skill. We'll start with the 3 types of thrust. There's impulse, body drop, and recoil. Impulse is an adaptation of what used to be called fast hands. So fast hands go fast, but they have to travel. Impulse is faster than fast hands, and it only travels a few millimeters. And when joints adjust and make a cavitation noise, all they do is gap a few millimeters. There's not a huge amount of movement. It's just a slight gapping. So impulse is what you're going to be trying to learn, so that you can take up contacts, feel resistance, and impulse to give you the adjustment. Body drop is not dropping your body. Body drop is about putting a constant pressure on the patient and then moving between your shoulders. This is how you practice it. You move between your shoulders. And then to thrust, you add an impulse. You drop your body and add an impulse. And this will give you that little short, sharp movement that's needed. Dropping your body we use for lumbar rolls, where we literally bend our knees, keep our hips bent, and drop our body. And we'll be doing that sometimes too. Recoil comes from the upper cervical specific technique of Palmer. And what it is you have to lean forward, have your knees bent, your back so that your arms are hanging loose, and you're going to contract your triceps and your pecs. So you learn it by doing slow contraction of pecs and triceps. Pecs and triceps. Then you learn to flick those into a recoil. And I'll be showing you some adjusting of the cervical spine using recoil and a drop headpiece. What we're going to try and achieve are therapeutic adjustments versus just cavitating joints. Therapeutic adjustments is changing the function around the 3 axes. Cavitation is taking a normal joint, gapping it so that it cavitates. But it wasn't dysfunctional, so it isn't therapeutic. Therapeutic is when it's dysfunctional, you get a cavitation, function changes, and it has a therapeutic effect. Change of the function around the three axes we often describe as the gang sign. That is, flexion, extension is around this x-axis, lateral bending is around the z-axis, rotation is around the y-axis. And what we have to remember is there's a positive and negative theta rotation around those axes. So it goes one way, comes back the other. It laterally bends one way, comes back the other. It rotates one way, comes back the other. And it's important to know that just because you make it move with a manipulation in one direction doesn't necessarily free up the other direction. So we often do a manipulation, rotation P to A and rotation A to P, or rotation flexion and rotation extension. The compensatory muscle spasms that occur when joints are dysfunctional are not where we want to manipulate. Do an adjustment. What we want to do is find the hypomobilities that cause hypermobilities and change the locomotor kinetic chain, which sets up troubles, pain syndromes, but also affects the sympathetic nervous system facilitation. And this is extremely important for overall health benefits. We need to repeat our adjustments. For each adjustment is demanding this change in function. And the body works off a principle called SAID. That's the specific adaptation to an imposed demand. Just like a weightlifter doing bicep curls. You wouldn't go to the gym once. You have to do a series of bicep curls. You have to bring it to failure. And the muscle responds specifically. Your quads don't get stronger when you do bicep curls. Right? It's specific adaptation to an imposed demand. We're going to demand joints move around these three axes, and we're going to repeat it serially. And the body, the patient's body, will develop elasticity, change the locomotor kinematic chain, and areas that have been irritated to the point of maybe producing pain syndromes will clear, or if the sympathetic nervous system has been facilitated, then we'll see a lot of other symptoms. Ringing in the ears, dryness of the throat, palpitations of the heart, all kinds of things occur when the sympathetic nervous system gets facilitated. Palpation is the way in which we determine whether we have hypomobilities or not. Josh, I wonder if you'd come over here and have a seat in front of me. What I'm going to do is have Josh take a very neutral posture. Don't have the patient flexed, and I don't want to overextend. When the spine is in neutral, the coefficient of friction between the vertebrae is 0. So I should be able to just spring the joints gently and pick up whether or not there's a block in this part of the spine. To start with, what I'm going to do is place my fingers down the back of the sacrum and see whether there's a little nutation and whether he springs back into counter nutation. Then I'm going to go to the right SI and see if it has a springy end feel, and come back and see if it has a springy end feel. If the SI is blocked, it's going to feel like pushing on a brick as opposed to pushing into a chunk of cheese, soft cheese. Then we'll come around L5, the sacrum, and we'll just do a little up motion with my hands. That little up motion will pick up whether or not something in this spine is blocking. The reason we do this is the patient comes in, has a seat, and I can find where I specifically want to adjust that day. We don't want to have to specifically test everything. It takes way too long, and it's a waste of time. So this brings us all the way up the upper thoracics, fingers and thumb just behind the articular pillars of the cervicals, and feel the springy end feel all the way up through the cervicals. Place my finger just in front of the tip of the atlas and see if the occiput has its little springy end feel. So, back of the sacrum, nutation, counter nutation, right and left SI, over the fifth, little upstroke, all the way up through the spine. If you meet something that's blocked, it's going to feel, and it's a hypomobility. It's that hypomobility, or those hypomobilities that you find, that you're going to do a specific motion palpation for. In each section of these tapes, I'll show the specific palpation and the specific adjustment for each palpation. While we are doing the quick scan, and if we find a spot that is hypomobile, I would trap it and maybe hyperextend it a little bit, or bend it to the left, and ask the patient, does that hurt? If the patient feels that it hurts at the end range when I can't feel it springy, I let the springiness off and ask the patient, has the pain gone away? If the pain disappears, this is the pain response of a manipulable lesion. This is the area that needs to be adjusted. If the pain lingers, that means there's inflammation of those joints, and there's probably another area that needs to be corrected, and this area would be hypomobile because of the inflammation causing local muscle spasm. So we don't want to be adjusting inflammation, we want to adjust joints that are hypomobile. So what I'd like you to do, Joss, if you'd come over here, this tape is going to be about the sacroiliac joints, and let's say I felt that his SI joints were not moving properly. Then I'm going to, if we just turn a little bit that way, that's great. I'm going to take a contact on the PSIS, the second tubercle of the sacrum, and have Josh lift his right leg, knee bent, high as he can, and down. And if you saw that he came up with his knee and then he moved back on his other knee, he should have stayed straight and brought his knee up. But because he couldn't flex his hip properly, or the SI joint wouldn't flex the innominate with the sacrum, it caused him to make a compensatory movement on the left. Now I'll have him lift his left knee. And this time the sacrum should move away from the PSIS. That's the same action as if he had extended the innominate. So the first action is flexion of the innominate against the sacrum. Lift your right knee. The second action, lift your left knee, is flexion of the sacrum against the innominate. We go over the other side. Left PSIS, tubercle, lift your left knee. Lift your right knee. And again, when he lifted his right knee, he made a little compensatory tilt of his pelvis. So it's not only a palpation, but you have to visualize how the patient is adapting to the dysfunction, if there is a dysfunction. Now we go to the lower SI joint. There's a bit of a controversy whether it's lower and upper or whether it's just one big ear-shaped joint. But Illy felt that it could rotate around its upper part, or it could lock in its lower part and rotate around the lower. So the axis of range of motion changes to the fixed point. So what we do is we go down from the PSIS, just where you fall into the muscle. If you come back, you'll be at the very base of the SI joint. Patient lifts their right knee again, and you should feel movement low down here. Patient lifts their left knee, you should feel the sacrum move low down. Go over the other side, come down from the PSIS, bend your left knee, flexes, right. That's it. So now what I've got is whether or not the innominate is moving against the sacrum, upper for flexion, lower for flexion, or whether the sacrum is moving against the innominate when you lift the other leg, which is the exact same action as extension. So I have an upper and lower appreciation of whether or not this SI joint is moving when I forward step which is flexion, or whether I back step, which is extension. Okay, Josh, if you would like to lie on your right side for me. When he lifted his left knee, that was testing the left innominate flexing or the sacrum flexing against the right innominate. So to adjust, we put the patient in the posture that we palpated the reduction of movement. So let's assume that when he lifted his left leg, the innominate didn't flex against the sacrum. So I'm going to put him in that same posture. I'll have him hold the table, put his arm underneath, and keep himself pretty perpendicular to the table. Now I should be able to bring his knee up, place my finger in the sacroiliac joint, and I should be able to push down and feel whether that joint is gapping or not. This will be a second appraisal of the left SI joint. We felt that it didn't happen in our gilet palpation. Now we'll see if it gaps with what's called joint play. If I bring the knee up too high, the tension will go up here. If I have it down too low, there'll be no tension there. So I have to have the knee, bring him over to the edge a bit, and then so that I can gap this, I push up. So there's a little up push, and I should feel, and it doesn't gap properly. So now I place, and I'll go around the other side of the table, and you'll see this better, but I'm going to place my knee to his knee and my thigh to his thigh. Now I'm going to create a little counter tension, take a piezoform, and get at that PSIS, push up, impulse. And that'll cause a gap and a release of the upper SI joint. Everything is made to be flexing, so the innominate flexes against the sacrum. If I was to do extension of the right joint, he would be in the same posture, only this time I would palpate the lower right SI joint. Bring the knee up for the tension, push up, block, so that I still have a slight up push, thigh to thigh. I want now the sacrum to flex, because I've set everything going to flex the sacrum against the innominate, the right innominate. All right, if you could lie over on the other side. From this side, I'll be able to show you the knee contact, pull the patient, that opens up, causes traction, have the patient hold the table, this hand under that arm, there we go. You saw me palpating the SI joint. Here's the push up. Elbow, knee to knee and thigh to thigh. And if you'll see my thigh, my pelvis is going this way, which makes me very powerful for a thrust on the SI joints. And then we got a really good release. Now some will make the mistake of coming across the lower leg. And this will lose. This puts another lever, another joint, so the force isn't direct. Plus it's difficult to push up to get that gapping so that when you thrust, it releases. Okay? It's the same. Come in, knee to knee, thigh to thigh, lower joint. My contact, and you'll see I'm there, and the thrust is the hip and the little drop of my body. So I'm thrusting and dropping. And that's where the power comes from. A golfer turns his pelvis to hit a golf ball. A baseball player turns his pelvis before he hits a baseball. There's nobody swinging like this. So we have to make sure that we load our pelvis to do these lumbar adjustments. Fine, we now have Casey on the table, and I'm going to show a supine method of adjusting the sacroiliac joint for flexion. With this, we're going to place the patient, come on down, Casey. The crest of her ilium are going to be on the lower part of the table, and I'm going to load the table, which has a drop mechanism. I'll take a little tighter. We're going to flex the hip to 90 degrees, and I'm going to have the heel of my hand on the ASIS. So I'll place my hand on the ASIS first. There's a little groove there that you want to hook over the top so that you're not pressing on the ASIS. That hurts the patient. So we're going to be just inside that, and the middle of the palm of my hand is contacting the ASIS. We'll bring the hip up to 90 degrees, and we'll take the knee medial so that we open the SI joint at the back. And with that, and a body drop. This is an excellent method if a woman is pregnant or somebody can't lie on their side, their shoulder just had surgery. There's all kinds of reasons people can't lie on their side, and this is an excellent way of doing flexion of the sacroiliac joint. Now I'd like to do extension. If we bring patient over to the edge so that the SI joint is just off the table, and we take the knee at 90, externally rotate it, bring the leg to a level with the table, and just throw it, the SI joint moves an extension. It's extremely easy. She felt her joint release, and if she was a 300-pound NFL lineman or somebody else that couldn't lie on their side, it's an extremely easy way to get the SI joint to move an extension. If you lie face down, Holly. And once again, we're going to have the patient's crest of the ilium on the lower table. And this time, I'm going to bring the hip into extension, which will cause the SI joint to start extending. I'll set the table with a drop, bring it up, get a contact on the PSIS, and she's quite flexible, so I have to lift her hip as high as I am and drop. And you can actually feel the SI joint go from neutral to extension. If you turn over onto your back, I'll just show that once again for the flexion. ASIS, hip at 90, drop. Good. Come over at the edge of the table, bend the knee, externally rotate, bring the knee to about level, and throw. And it releases. Okay, if you'd like to get up. Next, I'd like to show with Josh. If you'd come over. I want you to lie face down. Keep this foot on the floor, flat on the floor. Bend your knee. There you go. As you can see, come down so you're on the lower cushion. Okay. What we're doing here is the left side is flexing, the right side is extending. If I get and pull him up a little more, move your foot, there you go, and set the drop piece, I can effect extension on the right side, flexion on the left. So we'll just take out a little torque on the SI joints and drop. And sometimes this is the only way you can get the start of movement in a patient that can't lie on their back and can't lie on their shoulder. They can lie face down. You can do this. The lower joint is syndesmotic, or maybe it's below the actual diarthrodial part of the joint. And what we need to do is stretch. Since it's ligaments, they respond to a stretch, not to a dynamic thrust. So if you'll bring your knee up, we pull the knee up. If this right SI wasn't flexing very well, hold it 30 seconds and cause stretching of the lower SI joint. We then teach the patient to do this as a home exercise. We also, to gap and open the joint, have the patient pull their knee over to their left shoulder. So again, I would hold that for 30 seconds. Put this ankle on that knee. There has to be separation between the SI, the sacrum, and the lumbar spine. And with a lot of sacroiliac dysfunction, you start to get crossover where the muscles can't let go in the lumbars. There's a connection occurring that shouldn't occur. Lean forward. Keep going. Put your head down here. There you go. Keep going. Normal is, at her age, head to her calf. Most patients with sacroiliac dysfunction will be about here. And they have to do this at home 2 or 3 times a day to start separating the movement from their lumbar spine and SI so that they can do this. It obviously, too, is putting a big stretch on the hip joint. So eventually when we do our hip adjusting, we're going to give this to patients so that they can stretch the capsule of the hip joint. So we'll be doing a few things with that stretch, and all of it good. To test the nutation and counter-nutation, you can put a patient in this Sphinx posture, which actually you can start all the way from the thoracics and see if there's a good thoracic extension going on. And just push down through. But when you get to the sacrum, if you push on the upper part of the sacrum, you'll see if it nutates. If you push on the lower part, you'll see if there's counter-nutation. So again, it backs up your gilet palpation, testing to see if there's joint play, testing counter-nutation and nutation. Okay? Quite often the sacroiliac gets extremely painful because the symphysis pubis doesn't move properly or has complete instability as a postpartum problem. It also happens with football players, soccer players, hockey players, where their leg is going to be coming forward, something hits them, and they get a separation at the symphysis pubis. These people complain of chronic groin strains. And what needs to be done is you have to take an X-ray with them standing on about a 4-inch block with one leg hanging down. And you take a pelvic picture. And if the symphysis is unstable, it will separate. Rather than tilt with the pelvis, it literally drops. When I practiced in Europe, I saw this 2 or 3 times a year in soccer players. I've certainly seen it often as a postpartum sign. And this female, after having birthed, will have excruciating sacroiliac pain. And what we find, if we take that X-ray, is the symphysis has separated. These patients need to wear a trochanteric belt, keep it tight, even sleep in it, and things have to be held quite steady. But if it hasn't separated, as in most patients, quite often sacroiliac pain comes from sympathetic or the symphysis pubis dysfunction. So how are we going to palpate that? Can you just find your symphysis on this side? That's it. We're going to place the knee about like that, and I'm going to push down on her hands and see if it's springy, and if it's painful, it's usually extremely painful, and as soon as I take the pressure off, there'll be no pain because it's not inflamed, and that means we're going to have to adjust that side of the symphysis pubis. The patient puts their hand on the other symphysis, push down, bring the knee up a bit, push down. Again, it'll be very painful and it needs to be adjusted. To adjust it, we'll bring the patient down so that their iliac crests are on that cushion. We'll set the drop mechanism. Put your finger on the symphysis, knee at hip at 90. I'll get my contact right over the patient's fingers. It needs an impulse. So I got to get right on the symphysis and impulse. And that'll produce some movement where it's blocked, and the patient, with a few days, will start to feel less irritation, inflammation at the SI joint. We also know that there's a condition called Main syndrome, and this is irritation of the first lumbar nerve root, and that comes down into the SI area, around the crest of the ilium, into the groin, and it gives patients a sacroiliac pain that you would swear the sacroiliac needs to be adjusted, but your palpation would find the SI would be mobile and the thoracolumbar junction would palpate as dysfunctional. There's one last thing I want to show. Could you turn over face down for me? That's the sacroiliac dorsal long ligament. What we need to do, the PSIS, if we palpate just below that with a little transverse massage, that can be exquisitely painful on patients. Their hamstring will be tight because the ham attachment goes all the way and weaves into the dorsal long sacroiliac ligament. So they kind of become one. And when this SI ligament is under great strain and has been sprained or strained, it's exquisitely painful to touch, and that ligament has to be treated as a soft tissue injury as well as adjusting the sacroiliac joint. So that pretty much winds up the SI joint. We need to know whether or not the innominate can flex against the sacrum, whether the sacrum can flex against the innominate. Traditionally we called that flexion. So the failure to flex is what we're trying to correct. The extension we palpate as flexion of the sacrum against the innominate. That's how we adjust it. Or we adjust it supine, prone, whatever way is going to fit that particular patient.